My name is Eugenie Shu, and I am on the board of directors of the Raymond A. Wood Foundation. And we are pleased to present one of our learning series called Breaking Through the Issues of Diabetes Insipidus. And we're very happy to present Dr. Joseph Majzoub. And I'm going to read a little bio about him so that you can learn a little bit more about who our presenter is today. So Joseph Majzoub, attended the University of Michigan Honors College and Stanford University School of Medicine. These were followed by an internship residency and chief residency at Peter Bent Brigham Hospital and a postdoctoral fellowship in endocrinology at Massachusetts General Hospital and Massachusetts Institute of Technology. Dr. Majzoub joined the Division of Endocrinology at Brigham and Women's Hospital in 1981, where he remained until moving to Boston Children's Hospital in '89 as the chief of the Division of Endocrinology, a position he held for over 29 years until he stepped down in 2018 to become the vice chair for research in the Department of Pediatrics. Dr. Majzoub is the Thomas Morgan Roch Professor of Pediatrics and Professor of Medicine at Harvard Medical School. His clinical and research interests concern neuroendocrinology, especially disorders of water metabolism, and how stress influences health and disease. Dr. Majzoub is a mentor to many medical students, postdoc fellows, endocrinology fellow trainees, and faculty throughout the United States, and has received several teaching and mentoring awards from Boston Children's Hospital, Harvard Medical School, and the Harvard-MIT Health Sciences Technology Program. So let's welcome Dr. Majzoub. Thanks for joining us.
Thank you very much, Eugenie. It's my pleasure to be here. I am very impressed with all of you and with the Raymond A. Wood Foundation, and really appreciate your efforts to bring educational programs like this to patients and their families. I think the best way to start is with kind of an overview of diabetes insipidus. And I'm going to start by sharing my screen. And let's see how that goes. Presenter view. Let me get my pointer set up here so you can see my arrow. And I'm going to do one more thing. All right, here we go. So I have no disclosures myself to discuss, but I am going to talk about several drugs that are not approved by the FDA, but which we use despite that, including intravenous DDAVP, which is used subcutaneously, intranasal DDAVP, which is used orally, and mucosal DDAVP wafers, all to treat DI. I'd like to, my goal over the next 20 minutes is to give you my views of diabetes insipidus in ways that may help you understand the various causes of DI and their treatments so that you can reason things through on your own or with the help of your physicians and other caregivers. What I'm showing here is a diagram of the brain and the pituitary. And in dark blue is a neuron which makes AVP, arginine vasopressin, which is also called ADH, or antidiuretic hormone. These are the same thing. These neurons are present in the hypothalamus, which is at the base of the brain. It's a region about the size of a walnut, and it sends a projection, kind of a tail, or what's called an axon, all the way down into the pituitary, the back of the pituitary, which is called the posterior pituitary. The pituitary is the size of a cherry, between a raisin and a cherry, and it sits directly between your ears. The posterior part stores vasopressin. The reason that I'm showing this is because neurons, when they are severed, die. And when they die, they release their contents. as we'll discuss in a few minutes, most causes of DI that I see in my practice are due to the effects of surgery after the removal of a tumor or a growth such as a craniopharyngioma. The reason that DI happens is that oftentimes to remove that craniopharyngioma or other tumor, the pituitary stalk, which is this region that connects the brain to the pituitary, must be cut. There's just no way around it. When it's cut, these axons from the vasopressin neurons are also cut, and that results in initially, in the first day or so, let's say postoperatively, in DI, because this region that the pituitary is in gets filled up with blood and vasopressin can't get out, so it's trapped within here. But then in the next few days after that, vasopressin leaks out of these dying cells, and then it goes all over the body. And for a brief period of time, there's too much vasopressin. This is called the second phase of this triple phase response that happens after neurosurgery. And then finally, after the contents of these vasopressin-containing neurons has all been spilled out and these neurons are permanently gone, then there is permanent DI. So there's a very characteristic tempo of initial DI in the first day after the surgery, a period of up to 10 or 20 days of excessive vasopressin where sodium levels paradoxically get very low, and then permanent DI where the sodium levels then go up again. Now, this system that regulates vasopressin is actually quite simple, and I've diagrammed it here. Here again, we have the vasopressin neurons and their axons that go down to the posterior pituitary, just like before. Vasopressin is then secreted normally into the bloodstream, into the rest of the body, pumped through the body by the heart, where one of the major organs that it regulates is in the kidney. And in the kidney, vasopressin tells the kidney to do something very simple. In its presence, when vasopressin is circulating, it tells the kidney to reabsorb water back into the body. In the absence of vasopressin, such as occurs in central DI, it tells the kidney to excrete the water and not save it. So that's all it really acts as. It acts as a switch. When it's present, water goes in the kidney and back into the body. When vasopressin is absent, it goes out the kidney and into the commode. Here's another way to diagram it. We have water coming into the kidney through this red circuit. And then we have the urine that's made in the kidney that then comes out and goes into the commode. When vasopressin, normally when a person is dehydrated, in other words, they're very thirsty, they're very dry, that's when vasopressin is secreted, because it tells the kidney to hold on to that water that's coming through the kidney and go back into the body. And when vasopressin is absent, this doesn't occur, and urine contains more water, which then goes out of the body. Here's another way of thinking about this. Let's suppose the body is a vessel like this. And in the body, we have fluid, mostly water. And in the water, we have things like sodium in these green balls. When the level, and then there's this sensor that senses the level of sodium and the level of the volume in the vessel. You have an osmosensor in the brain, in the hypothalamus, and when that tells the body that the volume is low or that the sodium is high, that sends two signals into the body. One signal is that it signals the body to be thirsty, which then, if water is available, causes a person to drink. The second signal is to stimulate those neurons that I just showed you a picture of to secrete vasopressin. And then that causes the kidney to go from excreting water down here to stopping to excrete water, or anti-diuresis. whereas the thirst signal stimulates thirst, and then that causes water to come in from outside the person and drinking it to fill up this vessel back to normal. Now, it's really important to know that the way that humans are designed, they can do pretty well if they are missing one of these functions, thirst or vasopressin secretion. So for example, if you don't have vasopressin secretion, you have central DI, but you have good thirst, as long as you're given enough access to water, you can do okay, although you'll be drinking a lot and peeing a lot. If you have no vasopressin secretion, that's what many of you and your family are faced with. On the other hand, if one lacks thirst perception, so you can't tell when you should be thirsty, but if you have normal vasopressin secretion, you can get along pretty well because the vasopressin will be secreted as you get, excuse me, dehydrated, or your volume goes down, and that'll cause the kidney to conserve water. And it's not great, but you can get along okay like that. However, when you're missing both thirst and vasopressin secretion, so-called adipsia with DI, that's where we have real challenges. And I suspect that some of you or your family members are in that situation, and we can talk about that later. Now, I'm sure that many of you are very well familiar with the causes of DI. The most common cause that we see in our hospital, in Boston Children's Hospital, is due to surgery or trauma, where the pituitary stalk is cut necessarily because of the need to remove it so that one can remove a growth or a tumor. And as I said, that causes these neurons to die. One can actually have tumors themselves, which can interrupt this circuit. And the most common one is called a germinoma. And we see many patients with this. One can have infiltration of these areas. This is less common, but one can have Langerhans cell histiocytosis, or metastases from cancer, or other infiltrations with things like sarcoidosis or lymphocytic hypophysitis. One can have structural problems where from birth, because of the way the brain is formed, these neurons don't form properly. Now, here's a very important slide, and I'm going to tell you why I am showing it. What this tells us, what this plots, it's plotting how much salt somebody ingests, that then goes to the kidney, the so-called renal solute load in milliosms on the x-axis, and on the y-axis is the urine volume. What this graph, what you see is that as the salt intake by mouth goes in, and as it goes to the kidney sees increasing amounts of salt, the urine volume must increase. What this means is that for a person with DI, even if they have a completely steady amount of DDAVP, let's say that they're taking, or not taking DDAVP, they're just untreated, that you can control your urine volume in part by minimizing the amount of salt that you take in. So if a person puts themselves on a low salt diet, let's say that you cut your salt intake from 2 to 1 by half, the urine volume will also go down by half. So you cut the salt load from 200 milliosms to 100 milliosms, the urine volume will go down from 2 liters to 1 liter. And further, if you cut it fourfold, the urine volume will go down fourfold. So that's a really important thing to know, because one can, to some extent, control urine output by just deciding how much salt you're going to take in. If you eat a lot of pizza and peanuts and potato chips and French fries, you're going to have more urine output, even for the same amount of DDAVP that you're taking. All right, one of the last things I want to share with you is how we treat hypernatremia once a patient is gets into this situation. So hypernatremia simply means a high sodium concentration in the bloodstream. It can occur, for example, if one is not taking enough DDAVP or if one does not have access to water. How we treat it depends on how long it's been present. Let me explain this diagram. It has several different frames. In this top frame here, this is a normal cell. This is the outside of the cell, and this is the inside of the cell. The salt is present in these gray circles. This is normal. If you have acute hypernatremia, all of a sudden, let's say magically, you increase the serum sodium from 140 to 160. And so you go from not very many salt molecules to a lot here. Well, what's going to happen immediately is that water is going to be sucked out of this cell and the cell is going to shrink. And that's not good. If this has occurred just recently, let's say an hour ago, then one can simply give back the water and the sodium concentration will fall on the outside. Water will go back into the cell and it'll pop back into a normal shape. However, if this hypernatremia has been going on for more than 12 hours, which oftentimes it is, cells are very smart. And whereas initially the sodium concentration inside the cell was low, the cells start making their own molecules in the green here to help the cell maintain its normal shape. It's a protective mechanism that all cells have, including in the brain. But if you now increase the outside water rapidly, because there is an increased amount of osmolar elements solute inside the cell will not just go back to a normal size, it'll swell above normal. And if these cells are in the brain, and since the brain is enclosed within the skull, which is a fixed volume, you can have cerebral edema, which is very, very bad. It can actually cause very severe sickness and occasionally death. So the length of time that a patient is in this hypernatremic state will determine how rapidly one can change that back down to a normal state. If it's not been long, less than 12 hours, you can do it very quickly. But if it's more than 12 hours, it has to be very slow. The last thing I want to talk about is vasopressin and DDAVP dosing. First, I want to tell you a little bit about what DDAVP is. This is an amino acid diagram of vasopressin. This is the natural hormone that is made in the hypothalamus and normally secretes throughout the body. It has 9 amino acids. 1 is in this box. 2, 3, 4, 5, 6, 7, 8, 9. If you give vasopressin to a patient who has DI, it doesn't last very long if you just give them one shot, because vasopressin is a very short, it's very evanescent in the bloodstream. It actually only lasts about 5 minutes. However, very smart people came up with this molecule, which is an analog of vasopressin called DDAVP. You all know it. Why DDAVP? Well, the first D right here stands for des-amino. Des-amino means no amino group. Let me show you. See this? This is called an amino group. It's a nitrogen with 2 hydrogens here. The first change that was made for DDAVP was to get rid of this. There we go, it's gone. That's really important because that changes the half-life of vasopressin from 5 minutes to 12 hours. That's why in general, you can take DDAVP just twice a day or sometimes 3 times a day, because of the des-amino makes it last a long time. So where does the other D come from? Well, this 8th amino acid, which is arginine, is an L-arginine in the normal vasopressin molecule. But the second D is because that's changed to a D-arginine. So it's desamino D-arginine AVP, or DDAVP. What's the big deal about the D-arginine? The big deal is that normally vasopressin can bind to several different receptors, some of which can actually cause your blood pressure to go up. But DDAVP, because of the D-arginine, can only bind to the kidney receptor to cause water reabsorption. It doesn't affect your blood pressure. It doesn't affect anything, your stress axis or anything else. And so that's the DDAVP. We're not going to talk about oxytocin, although it's similar in its structure to DDAVP and to vasopressin. Well, I guess I will talk about it. So just very briefly, this is oxytocin. As you can see by the amino acid sequence, it's very similar, except that it has an isoleucine here instead of a phenylalanine, and a leucine instead of an arginine. And I think this is my final slide. And these are the types of DDAVP that we have available to treat patients with DI. Most of you are familiar with the oral form of DDAVP, which comes in the United States in two dose forms, 100 micrograms and 200 micrograms. And we dose between, in children and adults, we dose between 50 micrograms, which is half a tablet. Occasionally we cut a 100 microgram tablet into quarters, but between 50 micrograms and 200 micrograms per dose. And in general, we ask patients to take it every 12 hours until breakthrough occurs. And we'll talk about breakthrough, I'm sure, in the question period. In Europe and other parts of the world, there is a wafer form of DDAVP called Minirin, which is available in 60 and 120 microgram tablet. It's not available in the United States. And it's kind of neat because it's easier to break into smaller pieces, and you can just put it in your cheek pouch, and then it'll just be absorbed. You don't have to swallow it. But it's the same basic type of dosing. For infants, and we can talk about this in the Q&A, infants, if they're going to be treated with DDAVP, require much lower doses. And if you use higher doses, they can have severe hyponatremia. So we have ways of giving them very tiny doses of DDAVP, either using the nasal preparation, which is in adults or at older children, you actually sniff it up through your nose. That's how it was meant to be given. But you can actually give it orally in very small amounts. You can give a sub-Q preparation, which is normally given intravenously for a blood disorder caused von Willebrand's disease. But we use this routinely in infants and give them subcutaneous injections once or twice a day, and find it very helpful in managing DI in kids who are still taking liquid diets, in other words, nursing or on formula. So these are basically the ways that we treat patients. And that's all I wanted to present, but I'm sure that we're going to have some questions that I would love to answer. So thank you for your attention.
Thank you so much for the presentation, and I really appreciate your pictures. The images are very helpful. We do have quite a few questions, and so I'm going to ask them to you in some sort of order. Since you mentioned in your slides about dosing and breakthrough, why don't we start with that? So a general question would be, how do you determine dosing? And I guess I want to phrase it in terms of how much water should somebody be drinking per day? You've probably heard of some cases where people are drinking and drinking and drinking and drinking, and is that recommended? Do the kidneys handle that much volume of fluid? So how do you determine the dosing with drinking?
Right. Excellent question. So the first thing to say is that a person who does not have DI can drink almost a limitless amount of water without getting waterlogged. So a normal adult can drink 10 liters of water a day without lowering their serum sodium. Now, having said, so it's hard to overdrink if you don't have DI. However, if you do have DI and you're taking DDAVP, then you have to be very careful as to how much you drink, because the DDAVP locks the kidney into a fixed state that will not allow it to get rid of excess water as long as the DDAVP is high. So let's switch over. We're going to go back and forth on this because they're kind of like interdigitated. Let's talk about dosing.
Mm-hmm.
First of all, no one dose fits everybody. And people should not get too concerned about them or their family member taking twice as much or 3 times as much as somebody else. It doesn't work that way. We don't quite know how it works, but it's basically trial and error. So what we do is we start, I mean, in general, DDAVP lasts around 12 hours. So that usually when I start somebody on DDAVP, I give them a dose in the morning and a dose when they go to bed. And I'm very pragmatic about it. If you're going to bed, you don't want to be getting up at night to urinate. So I give them a dose right when they go to bed and right after they have broken through, usually. And we'll talk about breakthrough in a bit. And the goal is to let them sleep through the night without getting up to drink and urinate. So, would you say most of the people on this webinar adults or children?
That's a good question. I don't really know, but people can maybe.
Okay, well, I'll talk about both. In an adult, we typically start patients on 100 microgram tablets twice a day, one at bedtime and one when they get up in the morning after they've broken through. Ideally, I like to see people break through before their dose of DDAVP, both in the morning and in the evening. Now, even though I said that DDAVP lasts about 12 hours, it's a little bit more complicated. Well, it's not complicated, it's just more idiosyncratic than that. The higher the dose you take, the longer it lasts. Why is that? Well, think about it. If I want to introduce the concept of half-life of a drug, okay? The half-life of a drug is how long it takes for the concentration to go from its highest point when you first take it to half of that concentration. For DDAVP, it's about 12 hours, as I said. But it keeps working until it gets down to maybe about a quarter of its concentration of the peak. So if you start with a much higher dose, it's going to take longer to get down to that quarter concentration that causes it to be ineffective. So sometimes we can alter the window of how long it lasts by simply increasing the dose. So for example, somebody might be taking 100 micrograms at bedtime. And they say, Dr. Majzoub, I have to get up at 4 a.m. to pee, and I'm really thirsty. And I said, okay, we're going to increase you to 200 micrograms at bedtime. And that usually works to get them through to the morning.
Yeah.
Now, can I say a few words about breakthrough at this point?
Yes,
or do you want to?
Yeah, I would like you to actually define breakthrough, and if you could also make sure that you address whether or not breakthrough is recommended for everyone, including those who have adipsia.
Very good question. Let's tackle that second.
Yeah, let's define
Adipsia, as I said, is a really challenging situation, but it can be managed. So, do I recommend breakthrough all the time for everybody?
Well, could you please define it first? Sorry.
Yes. Okay. So, what is breakthrough? What is not breakthrough? You're not in breakthrough when you're not urinating very frequently. Let's say you're urinating once every 4 to 6 hours, and you're not thirsty at all. That's a good place to be, let's say, in the middle of the day. If you're in school and you don't want to have to go to the bathroom, or you're at work and you don't want to be bothered. Breakthrough occurs usually quite suddenly. Usually you're just doing fine, and then within about 10 or 15 minutes, you feel your bladder filling up. You have to go to the bathroom, and when you go to the bathroom, you go a large amount of really clear, almost water-colored urine. It's not dark yellow, it's light yellow, or even not yellow at all.
Yeah.
And you get thirsty, and you're thirsty. You have to drink. You can drink, and once you drink, you feel satisfied, but then about 10 minutes later, you're still thirsty. And 20 minutes later, you have to go to the bathroom again. That's what breakthrough is.
Okay.
Does that sound?
Well, it sounds like that's a great definition for people who have thirst.
Okay.
But if you don't have thirst, you can't say that they get thirsty.
That's right.
So could you?
So before I get there,
thirstless people.
Yeah. Before I get to that, with people who do have thirst and who are on DDAVP that they take, let's say 2 or 3 times. Sometimes you need a dose in the mid-afternoon. I like to advise patients to have breakthrough before each dose. And I try to adjust my dose so that happens. And sometimes you need to take more at nighttime, let's say maybe 200 micrograms at night and maybe 100 micrograms in the morning, and then maybe 100 micrograms at 3 in the afternoon, let's say after a kid gets home from school. All right. Now, let's talk about adipsia. Adipsia, I manage somewhat differently than what I just said. I find it, there are 2 ways to manage adipsia. Either one takes enough DDAVP to be in a constant non-diuretic state, no breakthrough, 0 breakthrough. And remember I showed you that the faucet and the spigot?
Yeah.
What I do in that state is I turn off the spigot at the bottom so that there's just a small amount of urine. It's not 0, but there's never breakthrough. And all of my effort goes into controlling the intake. And that's not easy, but and it depends obviously on the patient in terms of what they're capable of doing in terms of monitoring, and also the parents. But it's not that hard to monitor intake because you can measure it. It's much harder to monitor output because it goes into the toilet. It's hard to measure. But if you have 500 ml bottles that are all that we all now carry around with us, and if you're given a prescription of, let's say, 2 liters a day, then you take 2 liters a day. And on a fixed dose of DDAVP, let's say twice a day or 3 times a day, and if you do a few other things like weigh yourself, or the patient gets weighed every day, because there's a very direct relationship between the body weight and the fluid state of the patient. Then, and also you have to keep records, so that I think that one should actually keep a chart of daily weights. And if it's once and while you're getting adjusted to it, daily intake. And on top of that, just to know where you are, unfortunately, in the initial phases of this, you have to go and get your blood drawn to get a serum sodium checked. Now, I know that there are advances being made where that maybe won't have to take place in a lab. Maybe people can do it at home, but at this point, most people have to go to a lab for that.
Okay.
And then once you can get a sense for what is a amount of water fluid intake for the dose of DDAVP and at the body weight that maintains a normal or maybe slightly high serum sodium between 140 and 145, then you just stick with that. But then you have to be aware, I mean, it's a lot of stuff to think about. You have to be aware of whether or not the patient is losing fluid for another reason from another source. So for example, let's say everything's going very well and you're perfectly balanced and you're on 2 liters a day of water. And also you have to monitor how much salt you're taking in, because remember I showed you that graph, there's a direct correlation between the amount of salt you take in, the amount of water you excrete. So for example, somebody's doing very well, and then all of a sudden they eat a Big Mac with 3 helpings of French fries. That's a huge salt load, and they're going to need more water.
May I ask a question to clarify?
Yeah.
Do you mean that when someone takes in dietary sodium, that does it make the desmopressin less effective, or does it actually make the person drink more water?
It 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 essentially makes the desmopressin less effective. It
Okay.
doesn't make it less effective, but the body gets around the desmopressin because the salt can pull the water out of the body without even though the desmopressin is acting perfectly nicely and well,
Hmm.
the salt is kind of the culprit here, and it sneaks the water past the desmopressin so that it leaves the body and you get dehydrated. So the simple fix, though, it's fine to eat salt. I mean, a lot of, we all love French fries with salt, is to just drink more water, but you have to be aware of that. So one thing you have to be aware of is this: if the salt intake increases, the water intake has to increase. Number one. Number two, if there are other routes for water loss, like a fever and sweating, if a patient has a fever and is sweating, that's going to increase water loss, and you're going to have to increase your fluid intake, or you're going to get your sodium's going to go up. Or if you have diarrhea, if you're losing water from the bowels because of flu, you have a viral gastroenteritis, you have to increase the fluid intake. So the adipsia is such a, you have to take the place of the thirst center with your thinking
Yes.
this through, and that's a lot of work.
I understand. My son has very bad adipsia and takes actually 16 pills a day of the 200 micrograms every day. And I call myself a poor substitute for a hypothalamus.
That's exactly what you are. Well, you're probably a pretty good substitute, but
No,
that's what you have to
more
be.
terrible.
That's what you have to be.
Yes. Okay. Could we move on? Because there's quite a few more questions. Thank you for answering that. That was very helpful to know that adipsia is obviously handled very differently than people with regular DI. There was a question that wanted to ask about the diagram you had, where if somebody has acute hypernatremia, which you define as having a higher sodium level for less than 12 hours, and you had the diagram of the cells collapsing, you're shrinking basically, right? The question is, since it seems that it's dangerous to rehydrate too quickly, what is the definition of too quickly? Or what is the definition of rehydrating slowly enough in the case of someone with chronic?
In general, if in the hospital, I would define it in terms of how fast we would want the serum sodium to come down. But at home, you're not measuring serum sodium all the time.
That's right.
What I would say is, if you can think about how long it took the patient to become dehydrated, let's say it took about 2 days because they had a fever and they weren't drinking, and it took about 2 days to go from being well to being where they are. I would rehydrate them over that same period of time. So time it took to get into that state is the time that you should try to get them out of that state, and not try to get it all reversed at once. On the other hand, though, if it was quick, I mean, if you know that somebody was doing well and then just missed their water intake, like for the last 4 hours or 6 hours, then I just go right back and give it to them.
So just to be clear, so a lot of times, I mean, I have most experience with adipsia, so that's an extreme case, but somebody could just, let's say, have a breakthrough, and then their sodium could shoot up 10 points in a matter of minutes, right?
Yeah.
So would you recommend hydrating quickly? Like, could that
yes,
person really
yes, yeah, no problem.
Okay.
Because it's not 12 hours.
Okay, great.
Yeah, and day to day, with the fluctuations that they have, they can come back down as quickly as they can get that water
in. Okay, that's helpful, because I think some people are concerned about, do they need to do it slowly? Do they need to, have to, like you said, 2 days? But it's okay in a case of acute.
Absolutely.
To drink quickly.
Yeah, because it takes those brain cells many hours to adapt the way that I diagrammed.
Yeah. Could you actually, since we're talking about that, I'd like to ask the question, what are the risks or the adverse problems that happen when someone has hypernatremia and hyponatremia? What are the health risks
Yeah,
when someone goes too high or too low? Because we're always trying to prevent those,
yeah,
but some
yeah,
people need to know why.
yeah. Hypernatremia by itself isn't that risky. What is risky, though, is what it is associated with. Usually, when a patient is hypernatremic, they also are very dry in general, very dehydrated, which means that their blood is not perfusing their organs as well as it should, especially their liver, their kidneys, their brain. And it's the high serum sodium per se isn't so much of a problem, but it's the shrinkage of cells, it's the lack of blood perfusion of organs, and therefore they're not the organs aren't getting fuel like glucose, sugar, they're not getting oxygen. And so obviously it's important to try to avoid all of that, but the sodium itself isn't so much of a problem. I mean, we have, I see patients with a serum sodium of 180, 190, where normal is 140. And that itself doesn't cause problems as much as all the other things that go along. Hyponatremia is different. Cells do not like to have their sodium low. And that can be, and the reason is that especially in the brain, sodium is it's like the copper in a wire. It's what conducts the electricity through the brain. That's how a action potential, which is the nerve electricity, gets distributed and tells the brain what to do. When the sodium falls too low, none of that works properly. And you can have, for example, seizures, where a person will become unconscious and all of their muscles will twitch and things. So that's directly a result of the hyponatremia, the low serum sodium. And you can eventually become comatose, in other words, totally unresponsive because of the low serum sodium. And in addition, as I said, it is sometimes accompanied by swelling of the cells for the reasons that I mentioned.
So it sounds like the low sodium is much more dangerous than high sodium in general.
Yeah, although the high sodium is associated with other things that are dangerous.
Okay.
Like being dehydrated.
Yes. Okay. Here's a question. My daughter just started taking HGH, human growth hormone, about 6 weeks ago. We've noticed that her DABP needs have changed. She used to predictably take it twice a day with very obvious breakthroughs. Now she will go sometimes 12 to 15 hours on the same dose. Her breakthroughs aren't as obvious. She just doesn't seem to drink as much water. 2 questions. Could her thirst mechanism be malfunctioning? And number 2, we have increased her hydrocortisone dosage with the guidance of her endo. Should we be exploring other hormone replacements?
Yeah, that's interesting. Now, the growth hormone probably has nothing to do with any change in response to DAVP or thirst, but the hydrocortisone could have a lot to do with the changes in in how DAVP interacts. And this is one of my areas of research, is that hydrocortisone. So hydrocortisone is the same as cortisol, which is the stress hormone in the body. Cortisol is required to get rid of water, in addition to DAVP being required to hold on to water. In the absence of hydrocortisone, you cannot excrete a normal amount of water. And in fact, patients who have DI, sometimes nobody knows that they have DI because they have low levels of cortisol. And when that is given back, all of a sudden the DI becomes evident. Now, if the endocrinologist actually increased the hydrocortisone dose, I would have thought that would have caused the DAVP to become less effective. And I think from the question, it sounded like it's, if anything, more effective because the patient is not needing as much and it's taking longer for breakthrough.
A little longer, because normally it's twice a day. Now it's 12 to 15 hours on the same dose.
Yeah, so it seems like it's more effective in a sense. The same dose causes a bigger effect. I would have predicted that if as I understood it, the endo increased the dose of hydrocortisone or
Yes,
decreased.
increased.
Yeah, I would have thought that with increasing it, it would have gone the other way. But there are interactions between them. I don't think the growth hormone is having an effect itself.
Okay. Here's a question. Someone's asking. Some days the DDAVP seems to work, and some days the same dose doesn't. Why?
I would again ask if the salt intake is different on those days. Because you'll have an increase on the same dose and the same effect of DDAVP. You'll have a bigger urine output if you have a higher salt intake.
So again, on the salt issue, if someone drinks too much water, let's just say they're overhydrated, do you recommend them eating more salt?
No, I recommend them I recommend. That's why it's important to have breakthrough if you can, and if that's the treatment regimen, at least once a day, because then you can dump all that extra water. But no, I wouldn't do that.
You're not giving more permission to eat more French fries.
Well, you could. I mean, that will get rid of the water, but it wouldn't hurt, and it would work. But I would just wait for that breakthrough to get rid of the water. But yeah, if you want to finesse it a little bit, and I think that would work.
Okay. Here's another question. My son's sodium is this. We may need a little more clarification. My son's sodium is high when it should be low, and vice versa. He had a hamartoma removed surgically. No one is able to tell me why. What do you think that means? It should be. It's high.
Well, hamartomas, as I'm sure the writer, the person asking the question knows, these are normal tissue and kind of abnormal mixtures, and they are sometimes associated with precocious puberty. That's how we often see them, pick them up. But if that was not near the hypothalamus, and it could have been, maybe the patient has DI because of that. Oftentimes they are not near the hypothalamus. It shouldn't have any direct effect on vasopressin or sodium. So I think you're right. I think we need more information.
Maybe if we get more information, I can re-ask you that.
Yeah.
Here's a question about the change of weather. So with the hot weather coming in the summer, how do you manage DI same or differently in hot weather? And I think this may have to do with the insensible losses.
Yes.
How do you deal with that?
Yeah. So again, it depends on whether or not there is a sense of thirst or not. In general, if there is a thirst sensation, then with that increased water loss through the skin, one has to be very sensitive to increasing water intake, because it won't do to be taking in the standard. You can lose a liter or more, or an adult can lose 2 liters, especially with a lot of exercise and when it's hot, and if it's not too humid, and so you have to increase your water intake. Now, with a sense of thirst, that's kind of automatic, right? Because the person will just be more thirsty and will drink more. But again, especially with adipsia, you have to be very aware of that. And I guess I would try to avoid very hot settings. And so if one can stay in an air-conditioned setting during that type of heat wave, I think that would be really helpful.
That's better.
But in general, follow the thirst. And I wouldn't adjust the DDAVP dose, though. I would just adjust the amount of water intake.
Okay. Another question is if a person is, and I don't know if this is someone with adipsia or not, but if a person is having loss of fluids like diarrhea or is vomiting, how do you adjust for the DDAVP dose?
I wouldn't. I think they still need the DDAVP, and in fact, the DDAVP really should, if the dose is adequate when fluid balance is normal, you should keep it at that dose, but you should adjust the water intake to compensate for the diarrhea or the fever. Now, sometimes that's not possible. Let's say somebody has what's called a gastroenteritis or a stomach bug. Sometimes we have to admit those patients to the hospital. because they're vomiting, they have diarrhea, they have DI, they can't get any fluid in. And so we have to put them in the hospital to give them intravenous water.
Right. They can't hold it. They can't hold their
They can't hold it on their own.
Right. Yep. Okay. Here's an interesting question. I've noticed that DDAVP doesn't work as well for me when I go camping, which is always in the same location. Does elevation affect how well DDAVP works?
I have never been asked that question.
I told you it was an interesting question.
I'm wondering, this person must be a pretty good hiker because they must be getting up to like 10,000 feet or more. Let me think about that.
It's okay if you don't know.
No, I don't know. I don't know the answer. I'm thinking about the return of blood to the heart and how that is affected by altitude. And I suspect that the person is right. And in fact, you can give that person my, and you can give anybody my email address, and they can ask me a question directly if they want. But I would like to think about that a little bit more, and maybe learn more about that from that person.
Yeah. All right, let's see. Let me, I know we have a few more here. Let's see. Hold on. I know there's more. My husband, 71-year-old, has been feeling awful for about 3 weeks. He went to the ER last weekend. The labs were all okay, according to the emergency room doctor, but our endo said yesterday that he was low in sodium. She said to lower water intake. Does that help? Now, I'm not sure if this person has been diagnosed with DI. So the question is, does lower water intake help?
Yeah, so let me, I don't know, obviously we don't have enough information. But if the person was generally healthy and is 71 and now is a low sodium, then I would be concerned that something other than the vasopressin system is not working well. And the one thing I would do is think about the heart, because congestive heart failure is very commonly associated with a low serum sodium.
Right. They have a lot of edema.
Yeah, well, they can have edema, but the first thing that happens is that because the heart's not pumping very well, it's actually a vasopressin mechanism. Because the heart's not pumping well, the body thinks that it has a low volume, even though it doesn't. And it secretes vasopressin, which then results in water being held onto. So they should go back to their doctor and ask them about the possibility of checking out the heart.
Thank you that's good advice. Here's a good question.
Oh, wait a second. Here comes the person said, yes, he is a cranio patient. So I guess the patient does have DI. And but I would still say that you should look about, because again, it's not to say that couldn't be happening.
You could have it also.
Yeah, also. But I would, I guess I would, if he has DI, I would think about maybe less water intake, or maybe allowing for more breakthrough.
Okay. Here's a question that has to do with when one is hospitalized and one is getting rehydrated. What types of IV do you recommend? And I'm sort of reading into this about the amount of sodium in
exactly. Yeah, that's a good question.
How much? Because sometimes it seems like it's too high.
Exactly. In general, for a patient with DI, what they are losing is essentially water. They have a very dilute urine. So as best they can, they should be given back water. Now, water is very easy to give by mouth, unless you're adipsic and don't want to drink. But as long as you are willing to drink, it's easy to give. But you have to be very careful how you give water intravenously. It has to be given with a solute so that it doesn't cause hemolysis of red cells. And that is either with glucose, so it's called 5% dextrose in water. That's perfectly fine to give, or dilute sodium chloride, like 0.5 normal sodium chloride. they should not be given high salt in intravenous fluids because they're not losing that. And in fact,
Right.
that'll make them hypernatremic.
Right. That does not lower the sodium, which is the goal.
Right, exactly.
Okay. Great. I hope that answers the person's question. Um, Here's a person who's asked about whether or not it's ever possible to recover a thirst mechanism that has been taken away from the damage from this infection.
Not yet. I mean, it would be wonderful if it could be, but usually these are structural changes from surgery or from a tumor, and we know a lot more about where those neurons are. And if I had another hour, I could give you a lecture on that, but we don't know how to reconstruct them. No.
Yeah. No. Yeah. That's my son's wish.
Yeah.
He'd have a new hypothalamus. That would be great.
Yeah. Yeah.
Not yet. Okay. I think we may be coming short on time here. Maybe Amy could advise.
I have 7:56.
We have one more. Okay. Do you recommend that we not have IV fluids if the patient can drink water? What is the best way to,
By far, drinking is better than IV fluids.
Okay.
For rehydration with DI, yes, absolutely.
Well, that's really good for you. It's good to hear that because it seems that, and I'm interested in if other people have this experience that when we would go to the lab and my son's sodium would come in at whatever 160, which is not unusual for someone with adipsia, the doctors would freak out and they would say, you need to go to the hospital right now. And we're like, we'll just drink the water. But you're saying it's okay to drink the water.
Of course.
Okay.
And it's much safer. It's much, much safer.
Okay. Good to know. Well, I think we are out of time. So I just wanted to thank you again for this scintillating conversation about DI. And really enjoyed it. And I do hope that we have answered most of the questions here. As you kindly offered, if people have more questions, they can send you an email?
Yeah, sure.
Okay. And we can probably collect the questions and send them to you in one shot.
That would be great.
All right.
It's been my pleasure.
Thank you so much. And